Here is a father saying goodbye to his daughter for a pending deployment.
It's time for me to go, sweetie.
His third in the past 5 years.
I'm sorry.
This is tough to watch, and far too often a common occurrence. Frequent moves, separation from family, and exposure to violence and death are typical experiences for military members, but these experiences have a significant effect on the children as well. Studies have empirically shown that harmful effects of deployment on children, decreased academic performance, and poor peer and family relationships are noted in military children whose parents are currently deployed. Children whose parents have recently deployed had an increased risk of alcohol and drug use, fighting, and weapons carrying. In addition, rates of psychiatric diagnosis, psychiatric prescriptions, and psychiatric hospitalizations are higher with children whose parents deployed during their lifetime. These tendencies show the complexity of the military adolescent population and the difficulty of addressing their needs using traditional behavioral health service models. The Pediatric Behavioral Health Team, located at Tripler Army Medical Center, identified the need for innovative services for this vulnerable population. So in 2000, they transformed from a traditional consultative model that primarily occurred in a clinical setting as the one pictured here, to an embedded school behavioral health model, which brought treatment to the child's natural environment, with clinicians and school staff proactively working in concert to effect change. This was a revolutionary endeavor for Army medicine. It had incredible success. Since its inception, the embedded school behavioral health model has been adopted by 14 military installations. The original architects of this best practice have since migrated to Washington State, heading up the program in Fort Lewis. Captain Martin sat down with them to get a first-hand account of their experience with this outstanding program.
So my team and I, we have just a few questions regarding the incredible program that you guys have pioneered in military healthcare. Can you please explain what the embedded school behavioral model looks like?
Really what it is it's a part of a system of care. The whole idea is to first put resources as far forward as possible for kids, the same way that we put resources far forward for soldiers when we're in combat. So you want the behavioral health resources where they spend the most of their day. And then what you want is you want resources that are integrated with other systems that touch families. Things like primary care. You want them involved in any of the community activities that are going on in the community. You want it to benefit all kids, not just kids who have problems. Because what it really is a system integrated in the school to benefit the entire school population of children.
How is this model superior to the traditional model?
The traditional model is clinic-based behavioral health. If you look at kids as being in a pyramid, with the lower portion of the pyramid being all kids, the second layer being kids at risk, and the top layer being kids who have significant problems, we really only take care of the top layer of kids in the clinic. So we're not impacting all the kids. We're not promoting the resilience and wellness. We're not helping the school to develop a healthy culture, a good climate. And sometimes we actually help restructure things so it's best for all people who work and study at schools, not just the kids, but also the teachers, supervisors, administration, that sort of thing.
Can you give us an example of a success story from your program?
I think the best success story comes from the clients, the parents. And so I'd like to just read a quote that was shared, and she says, "It's hard to express in words how much it has meant to us. He now has tools that will help him be successful, not only in school, but at home and in other social situations. It has also helped Father to complete his mission because there is less concern with having to leave work or worry about things that he can't control." Prior to the student being enrolled in school behavioral health, and for the first 2 months of therapy, the parents would receive calls about 2 or 3 times a month to come and pick up the youngster from school because of behavioral and emotional issues. 4 months through the therapy, there have been 0 calls.
In conclusion, the embedded school behavioral health model improves patient behavior, academic performance, and quality of life. Army Medicine plans to implement this model in more than 100 schools by the end of FY17. It is our hope that this best practice is universally implemented throughout the MHS.